lecture on the said topic. Over to you, Dr. Gautam.
And
I'll stop share and then you could go.
Yes, thank you, Dr. Eshwar, for that kind introduction, to Dr. Kavitha for organizing this, and to all of the attendees today. And I'm pleased to be here. I will be talking today on Atelectasis consolidation, ground glass opacity, and mosaic attenuation. So the learning objectives today are to identify lobar or rounded atelectasis, to describe the differential diagnosis of consolidation, to discuss some causes of ground glass opacity, and to differentiate mosaic attenuation from ground glass opacity, as well as to recognize what's called the head cheese appearance, which is a heterogeneous appearance in the lung. So let's start with lobar rounded atelectasis. Okay, so what do we have here? We have a patient who has this right upper lobe consolidation here. And notice that this interface is curved, and we see that here as well. So what sign is present? Well, the Hampton's hump is usually a wedge-shaped consolidation or wedge-shaped opacity in the periphery, and that's associated with pulmonary infarct. Luft-Sickle sign is air that's here, and that's associated with left upper lobe collapse. Figure 3 is the sign that we see in the aorta that is associated with coarctation of the aorta. And then here, yes, I see some people putting in the chat, it's A, the S sign of Golden. Good, so this is the S curve in the road, and that's the S sign of Golden. So it's actually a reverse S. It's inverted, in other words, it's mirror image, but that's characteristic of right upper lobe collapse with a mass in the hilum pushing this border inferiorly. So it's either hilar or perihilar mass with the collapse. Notice that this patient also has right upper lobe collapse, but there's no bulging here. There's no prominence here. So this is not likely to be a big mass there. There could be an endobronchial mass. So it doesn't mean that there's no tumor here. It's just that it's unlikely to be a big mass in the hilum. Another patient with a much tighter right upper lobe collapse right there. And that is also right upper lobe collapse. So what are some causes of lung collapse? There are some issues to be concerned about. So right upper lobe is the S sign of Golden, as we just said. Left upper lobe collapse is often difficult to see on radiography, but we look for the Luft-Sickle sign on the PA or AP radiograph. If the right middle lobe or lingula is collapsed, we see heart border obscuration, and then sometimes we see right middle and lower lobe collapse because the bronchus intermedius is involved, in which case the heart and diaphragm will both be obscured on the right side. And in the lower lobe, especially the left lower lobe, look for a triangular opacity, and that indicates collapse. Okay, what are some causes? Well, in outpatients who are adults, think about tumor. In older individuals, especially patients with a smoking history, think about carcinoma of the lung, but carcinoid is also a possibility for an endobronchial lesion. It could be extrinsic compression by a mass or endobronchial mass causing collapse. In inpatients, mucus plugging is the most common cause, and the other cause is aspiration, so plugging of the bronchus, either with mucus or aspirated material. In children, we think about foreign body aspiration. And some other causes that we should consider: broncholith in granulomatous disease and tuberculosis, for example. There is going to be calcification of a lymph node that then erodes into a bronchus, and that's called the broncholith. Right middle lobe syndrome, which is a non-obstructive cause of right middle lobe collapse. And And then compressive atelectasis, generally related to pleural effusion, but it could also be due to a pneumothorax. Okay, how about this particular patient here? What are the findings that we see here? I think this is more subtle. If you're only looking at the PA film, it's relatively hard to see, but I think you can see that there's this haziness up here in the left upper lobe. The lateral view is a little bit more clear in that we see this dense area anteriorly. So what sign is this? Any thoughts about what sign this might be? So it's not that sign of Golden, which I showed you already. Hampton's hump, which would be the wedge-shaped consolidation. Yeah. So I'm seeing some people are favoring C. So that is this lucency there. So let's go to it a second. Okay, so I'm just going to go back to this for a second. So this lucency is a semicircular or sickle-shaped lucency. So in German, that's called the air sickle. So Luftsickle is air sickle. It's right there. That is the superior segment of the left lower lobe that's coming up medially and showing the air right there. And look at the veil of opacity. This ill-defined opacity in the left upper lobe is called the veil of opacity, caused by this, which is left upper lobe collapse. It's anterior collapse. So the veil of opacity, you can still see through it, but it's just very hazy right there. So these findings together, that veil of opacity and the Luftsickle sign, are consistent with left upper lobe collapse. Again, when we see this, it's almost always due to a tumor that's obstructing the bronchus, either endobronchially or extrinsic compression. And the lateral view, it's much easier, as I said. Okay. Another patient with left upper lobe collapse. The Luftsickle sign is here, and then this veil of opacity. It's a little bit more volume than the other patient who had a very tight collapse anteriorly. Okay, how about this patient? This patient has bilateral findings. Notice that the hemidiaphragm on both sides is obscured. So we definitely see findings there. So I'm going to first just briefly talk about this, which Tribeca is a neighborhood in New York City, and that means triangle below Canal Street, and that's this area. And so I call this triangle back here, I call that Tribeca. So this is not anything that's official. This is just something I tell my residents. This is Tribeca. When you see Tribeca, the triangle behind the cardium, behind the heart, that is collapse of the left lower lobe. And this is an area that's frequently missed by more junior people, by residents who are starting, because they don't see anything here. But remember, always look at the diaphragm. Make sure that you can see the diaphragm. Make sure you can see the descending aorta. If that triangle is filled in, then it's definitely abnormal. That is the collapse of the left lower lobe. Okay, but this patient has something else. How about on the right side? Look at this triangular area here. Notice that the right heart border is also obscured, as well as the hemidiaphragm. So the right heart border is obscured with right middle lobe collapse, and the lower lobe obscures the diaphragm. Okay, let's move on. On the PA view here, it's really subtle. Maybe there's something there, but I'm not sure. How about on the lateral view? So we do see this anterior opacity laterally right there. So that is a patient who has collapse of the right middle lobe. So that's the upper lobe that came way down to fill up the space, and this is the lower lobe. The right middle lobe is completely collapsed. Now, is this caused by an endobronchial mass? Is it caused by mucus plugging? Well, look at the airway. The right middle lobe airway is completely patent. Look at the smaller airways, completely patent. So this is right middle lobe collapse with without airway involvement. So this is called right middle lobe syndrome, in which there's no obstruction. So right middle lobe syndrome is a chronic right middle lobe collapse with no bronchial obstruction, persistent or recurrent cough, intermittent wheezing, dyspnea, and history of recurrent pneumonia. These are some things you might see in the history. On the AP or PA film, it can be really difficult to see, but it's more obvious on the lateral view. Let's move on to this patient. What do we see here? So you can see in the left lung, there's this mass-like area here. Okay, so what is the most likely diagnosis here? So I can tell you, let's come back for a second. I can tell you, look at the pleural thickening here. And I can tell you some history. This patient had a history of asbestos exposure. Okay, so history of asbestos exposure. So there's some people favor rounded atelectasis. So let's look at that. So first of all, I want to tell you about the comet tail, the comet. So Halley's comet last came in 1986. It comes once every 76 years, and it was described more than 400 years ago by Sir Edmund Halley. And you can see this tail there. That's because there's ice here that's melting as it gets close to the sun. Okay, so in rounded atelectasis, we see 4 features. If we can see all 4 features, we can say it is likely rounded atelectasis, but it's not a definitive diagnosis. We still have to follow it with follow-up CT because it could still be lung cancer. But if we see 4 features, we are less concerned and we can just follow with CT to make sure that it's stable for 2 years. So what are the 4 features? Well, there needs to be an ipsilateral pleural abnormality, which we see here. It could be pleural effusion, pleural thickening. There needs to be broad area of contact with the pleura, which we see there. Not just tangential touching for 1 millimeter. It needs to be broad area of contact. We need to see volume loss. Notice that the left lung is smaller than the right. There's definitely volume loss here. Look at the ribs, they're closer to each other than on the right side. And the 4th sign is swirling of vessels known as the comet tail sign. And we see actually a few areas that look like that. This one, and then here, and then potentially there. So there's definitely at least 1 comet tail sign here. This patient has all 4 features of rounded atelectasis. So we will simply say likely rounded atelectasis and we will follow the patient. There's still a risk that this could be lung cancer mimicking rounded atelectasis. If they don't have all 4 features, then we have to do a lung cancer workup. We might do a PET CT and then go from there. That's if we can't establish the diagnosis of rounded atelectasis. So again, volume loss, ipsilateral pleural disease, such as pleural plaque or thickening or effusion, broad area of contact with the pleura, and swirling of vessels known as the comet tail sign. This is associated with asbestos exposure, although people without asbestos exposure can also get this. And we do need to follow up with CT. Don't just say rounded atelectasis and end it, because it could be lung cancer. Another patient, look at these sagittal views. We can see here this ipsilateral pleural abnormality. This is pleural effusion with the mass-like opacity. Notice that the fissure is curved, so it's being pulled down, so there's volume loss, broad area of contact with the pleura, and these vessels here, the comet tail sign. So another patient with likely rounded atelectasis. Okay, I'm just going to skip this particular slide, but well, maybe I'll talk about it. So radiographs, sometimes patients ask, how much radiation is this am I going to get? And a good way to describe it is to say what it's equivalent to. Chest radiograph, for example, is similar to a transcontinental plane ride in North America. So going from New York, let's say, to Seattle, where I live, you get similar radiation exposure to chest radiographs. An international flight crew traveling multiple times during the year will get equivalent to one CT scan when they're writing. So this is one way to address these types of issues. Okay, so now let's move on to CT for the rest of the talk. And I'm going to talk about increased and heterogeneous lung opacity. So let's start with increased opacity. If the vessels are obscured on a CT scan, that's called consolidation. If the vessels are not obscured by the opacity, that's called ground glass opacity. So that's an important distinction because the two different opacities will give us different differential diagnosis. Okay, so here we see peripheral areas of consolidation. Notice that they're patchy, bilateral. There's also some areas that are a little bit less dense. There's a little bit of ground glass opacity, but it's primarily consolidation, multiple peripheral areas. So which of these could it be? Which one do you think it might be? Okay, so there are multiple peripheral consolidations. Infarcts are usually, oh, I don't know what's going on there. Okay, so infarcts are usually going to be one or two or at most three. You're not going to see 10 infarcts. That's extremely unlikely. So it's either B or C. Septic emboli are rounder and they cavitate. Eosinophilic pneumonia or organizing pneumonia, like cryptogenic organizing pneumonia. The only thing is eosinophilic pneumonia is associated with peripheral eosinophilia, and we will get the same appearance as this, but organizing pneumonia is more common. Okay, for some reason my annotation is on. Okay, there. So organizing pneumonia is more common, like cryptogenic organizing pneumonia. Okay, so that's what I would say is the most likely diagnosis. This one turns out to be eosinophilic pneumonia. But if I had to say what's most likely, I'd say organizing pneumonia first, eosinophilic pneumonia second. And a clue is, again, peripheral eosinophilia. In other words, in the blood smear, we will see eosinophils. Okay, so let's move on to our next learning objective, which is describe the differential diagnosis of consolidations. So consolidation is a situation in which the alveolar air is replaced by water, blood, pus, protein, or cells. The underlying vessels are obscured, as I said. And, atelectasis, we consider atelectasis to be a form of consolidation because the air spaces are filled or just collapsed. They're filled up by lung. Okay, so causes of consolidation, we think, of course, pneumonia, TB, aspiration, but also remember atelectasis, contusion, and hemorrhage. On radiographs, hemorrhage can look like consolidation, but on CT, it usually presents as ground glass opacity. It's a little bit less dense on CT. So we see a lot of trauma patients in one of our hospitals here, and there we'll see a lot of contusions, especially after motor vehicle collision with rib fractures. And then aspiration and atelectasis frequently occur in the lower lobes. On radiographs and inpatients, we see that all the time. Okay, so in patients with peripheral consolidation, think about it, cryptogenic organizing pneumonia, chronic eosinophilic pneumonia, and pulmonary infarct. I wrote single focus there, but sometimes they're 2 or 3. Okay, we have a different patient here with some peripheral areas of consolidation, and again, mixed with ground glass opacity. So let's look at this. So what sign is present here? Okay, so bird's nest sign is associated with atypical fungus like rhizopus or mucormycosis that occurs in immunocompromised individuals. Atoll sign is associated with cryptogenic organizing pneumonia. The halo sign is associated with a fungal infection like angioinvasive aspergillosis. Crazy paving is associated with alveolar proteinosis, but much more commonly with other things, but classically alveolar proteinosis, which is extremely rare. And E, I just made up as, that's not a sign, obviously. Okay, so most of you said B, which is absolutely correct. This is the atoll sign here, in which there's a dense periphery and a more lucent, there's also density in the center, higher opacity, but it's less dense, more like ground glass opacity. That's an atoll. It's the top of a undersea volcano. And this is the crater, and it just happens to come up a little bit above sea level. So we see more centrally that there's water, and then peripherally there's land. So that's why we call that the atoll sign. And the most likely diagnosis, as I said, is organizing pneumonia. Okay, another patient with cryptogenic organizing pneumonia. It's characteristic to have these peripheral consolidations. We don't have to see the atoll sign as we see here, but if you see it, it helps you with the diagnosis. Is this pathognomonic, this atoll sign? No. You can see atoll signs in other diseases as well, but when we see it with this pattern, think COP as number 1. Okay. Another patient, cryptogenic organizing pneumonia with these peripheral consolidations, not quite as obvious as the other one. And how about this one? There's a peripheral wedge-shaped consolidation, a patient with acute pulmonary embolism. And notice it's heterogeneous. This one is a pulmonary infarct, also peripheral, but usually there's only 1 or 2, at most 3. I've never seen more than 3. There may be, but it's just uncommon. Okay, let's move on to talk briefly about chronic consolidation. So adenocarcinoma can cause chronic consolidation. It's really important to remember that because it mimics pneumonia on a radiograph. So on a CT, it may present as ground glass opacity that's chronic, or it could present as chronic consolidation. On a radiograph, it often presents as a consolidation. One of the important things to remember, if we do a PET scan, we're concerned about adenocarcinoma, we do a PET. If there's ground glass as the primary presentation, it's often false negative on PET. So it doesn't have to be false negative, but it could be. So don't rely exclusively on the PET. We still have to follow it up, even if there's a negative PET scan. We still have to do follow-up CT. And establish stability for 5 years for ground glass opacity. If it's not stable for 5 years, then it could be malignant. Okay, so other causes of chronic consolidation, I showed you examples of organizing pneumonia and eosinophilic pneumonia. Lipoid pneumonia is another cause. That's with generally aspiration of oils, of a type of oil. And then Hodgkin's lymphoma rarely can cause a chronic consolidation. So let's look at this patient who had cough for 6 weeks. We saw this area, likely pneumonia, but I will always dictate in anyone who's over 35 years old, I will dictate follow-up radiography in 6 to 8 weeks should be performed to assess the possibility of malignancy. Because if this does not go away after treatment, then we have to be concerned about adenocarcinoma. This is 6 to 8 weeks later after treatment. It's still there. Actually, this is the exact same image, but it looked the same. I just don't have those images. And this is an adenocarcinoma. It turned out to be an adenocarcinoma on further diagnosis. Okay, so let's look at some other entities that we're seeing here. So what does this patient has? There's extensive ground glass opacity. So what's the predominant finding? It's ground glass opacity. I guess I just gave away the answer there. But mosaic attenuation is going to be more patchy. Consolidation is clearly denser, and it's not emphysema. There's no lung destruction. But you can see opacity, and the vessels are clearly seen through the opacity. Now, I just want to clarify a little bit. If we see a patient who has a contrast-enhanced CT, then we can definitely see contrast-enhanced vessels through consolidation. But I'm talking about non-contrast CT. We should not see vessels through the consolidation in a non-contrast CT. We see the vessels. This is ground glass opacity, not consolidation. So what's the most likely diagnosis? This patient has a history of granulomatosis with polyangiitis, or GPA, formerly known as Wegener's granulomatosis. That term is disfavored now. We now call it GPA. So what's the most likely diagnosis in this patient? Yeah, good. So I see the answer D, or hemorrhage, and that is definitely correct. Hemorrhage is most likely in a patient with GPA to show this appearance, but it could be any of these. Any of these can cause this appearance. Ground glass opacity has a broad differential diagnosis. So we need to use the history and also see whether it's, see the chronicity, how long has it been there? Do we have prior studies? So next, sorry. I'm sorry, can you hold on 1 second? It is saying that my Mac is going to sleep unless I plug it in, and it's plugged in. So I just need to double check this. Hold on, please. Okay, I apologize for that. Let me plug it in. Okay, so now let's discuss the causes of ground glass opacity. So ground glass is glass that is rubbed with a rough material that makes it translucent. So that's what ground glass is. And notice that we can see through it just as we could see vessels through areas of ground glass opacity. So, by the way, what language is this? Does anyone know? This turns out to be Finnish. The other 4 languages are all Germanic, North Germanic languages that are related to English, whereas Finnish is completely different, and it's not even an Indo-European language. So that was just an aside. So let's talk about ground glass opacity in more detail. So this could be airspace disease, interstitial disease, or mixed disease. There's a hazy increase in lung opacity. The underlying vessels are not obscured, as I said, usually indicates an active process, and it can lead to biopsy in the correct clinical situation, in the chronic situation, especially in the setting of interstitial lung disease. And if there's fibrosis, then ground glass opacity is very common, commonly associated with fibrosis, and it's likely not an active inflammation at that point. It's likely just an indicator that there's fibrosis. So with ground glass opacity, if there's no reticulation, no lines, then it's likely active disease. And there's a long differential diagnosis, but important things in the acute setting with ground glass opacity, I always think about edema and pneumonia, such as viral pneumonia or pneumocystis pneumonia. Those are the two most likely things, edema and viral or atypical pneumonia. Hemorrhage can also occur, but it's much less common. So those are the things that I consider in the acute setting. In the more chronic setting, hypersensitivity pneumonitis is an important consideration, and others are just less common. But COP and eosinophilic pneumonia, if there's peripheral consolidation or ground glass opacity. Okay, so this patient we've already discussed, this patient has hemorrhage, but I'd also consider in this patient pulmonary edema and pneumonia. Pulmonary edema tends to be more central, so I think that's unlikely here, but it could be. The pneumonia is definitely a possibility, viral pneumonia, pneumocystis. Okay, this is a different patient, diffuse lung disease, diffuse ground glass opacity, same differential diagnosis. So this patient is HIV positive, so we definitely have to think about pneumonia, especially pneumocystis pneumonia in HIV positive patients, and as well as viral pneumonias like CMV. So this is pneumocystis. Different patient, notice this is more focal and patchy. This ground glass opacity is not diffuse as we saw in the other patients, but pneumonia also looks like this, especially viral pneumonia can be focal. Okay, so how about ground glass opacity with reticulation? So assuming there's no fibrosis, just assume that there's septal thickening or interstitial thickening, then it's likely an active disease, meaning active inflammation. It could be NSIP, nonspecific interstitial pneumonia, if it's more chronic. But this is called the crazy paving sign. And in the acute setting, crazy paving is much more common to cause an acute disease like edema, atypical pneumonia, or hemorrhage. Alveolar proteinosis is the classic association, but that is really rare. And when we see crazy paving, it's usually not alveolar proteinosis. It's usually one of the others, and it's more acute. Okay, so this is a patient who has ground glass opacity, and you can see all this reticulation. There's not just septal thickening, as we see here, but there's fine interstitial thickening. So this is the classic crazy paving sign. It's asymmetric. As I said, it's usually not acute. This is usually acute, and the differential diagnosis here includes pneumonia, like viral pneumonia and pneumocystis pneumonia, as well as pulmonary edema and hemorrhage. Why does hemorrhage do this? Because there's the hemorrhage, the blood causes the ground glass opacity, and then the blood is resorbed into the interstitium, and that causes the thickening, the interstitial thickening. So, but this patient had chronic disease, so the most likely diagnosis is clearly going to be alveolar proteinosis. This is a classic appearance of alveolar proteinosis, which is extremely rare. It's a rare idiopathic disease. It occurs in younger men. It's very difficult to treat. One way to treat is to do bronchoalveolar lavage, but they usually only do one lobe at a time, and they do it every few months in a different lobe. And then by the time they finish it, then the original lobe done about a year earlier or a year and a half earlier starts to rebuild. So they have to go back and do that again. The risk of bronchoalveolar lavage and alveolar proteinosis, the risk of death is high. Relatively high, so they just have to be really careful. Okay, so what does crazy paving mean? I never understood that term. I knew it meant something was crazy, but it means that the paving is not uniform. You see these paving stones, and that was common in 16th century gardens in England. They didn't call it crazy paving at that time, but subsequently in the 17th and 18th centuries, when the style became much more uniform and rectangular paving stones, then they call this in retrospect crazy paving. And that's why we have this sign, the crazy paving sign, because it looks like this. Okay, so this patient turns out to have alveolar proteinosis. A different patient, this isn't as classic as the one we just saw with this fine reticulation. Instead, we see the ground glass opacity and we see the reticulation here. This is the septal thickening and then finer reticulation within the interlobular septi. So within the pulmonary lobule, the secondary pulmonary lobule, you see this finer reticulation. So this is also crazy paving, but you may not think of it as obviously as this one. It's still crazy paving with the same differential diagnosis, probably edema or pneumonia, less likely hemorrhage. And it could be alveolar proteinosis if this is chronic. This turns out to be viral pneumonia. And another patient similar with this septal thickening, some finer reticulation here, for example, here and here, finer reticulation, and ground glass opacity. This patient had pneumocystis pneumonia and HIV. Okay, and another patient with crazy paving and alveolar proteinosis. Notice it's patchy. That's quite common. Okay, so now let's talk about heterogeneous or decreased lung attenuation. So primarily, we're talking about heterogeneity that's patchy. So if the small vessels, if the vessels are small in the dark areas and there are fewer vessels, that's mosaic perfusion or mosaic attenuation. That's the same thing. Mosaic perfusion is the same thing as mosaic attenuation. It's just a different name. So if the vessels are small, that's mosaic. If the vessels are uniform across all of the lung, that is ground glass opacity. So I'll show you what I mean. So let's look at this patient who has these areas of higher density and these areas of lower density. The question often is which area is abnormal, which is normal. Most people, when they read this, they just assume it's ground glass opacity, but we can't assume it's ground glass opacity. We have to differentiate patchy ground glass opacity from mosaic attenuation. The official definition is if you look at an area with the denser area and you look at the darker area, are the vessels similar in size? You cannot compare the non-dependent lung with the dependent lung because there's going to be more blood flow here and the vessels will be larger. But you need to compare adjacent areas of lung. Are the vessels similar in size? And I think here they probably are. And I'm saying probably because this is really difficult to differentiate. So that's the official definition. I use another definition that is much easier, which if there is sharp demarcation between the white and dark areas, that is mosaic attenuation. In other words, if you could draw on here, I don't draw on your computer screen, of course, but if we can take a pencil and draw the border between the whiter and darker areas, that's mosaic attenuation. If you can't draw, the borders are ill-defined, then that means that this is ground glass opacity. So in mosaic attenuation, the dark areas are abnormal. In ground glass opacity, the white areas are abnormal. The denser areas are abnormal. And it seems like you should be able to tell, but we can't really tell which is abnormal and which is normal just by looking at the white versus the dark, because sometimes mosaic attenuation and ground glass opacity look very similar. So don't just say this is denser, so it's ground glass opacity. It may be in fact normal and this darker area is abnormal, so it's mosaic attenuation. So in this patient, I cannot define the edges. In other words, if I had a pencil, I couldn't draw the edges here. So I would say this is patchy ground glass opacity. So this patient works in an aviary in a birdhouse. So what's the most likely diagnosis? I think we know it's bird fancier's lung or hypersensitive pneumonitis is the disease. And in subacute and acute hypersensitive pneumonitis, we frequently see the ground glass opacity. Even in the chronic setting, we can see ground glass opacity as the primary finding. Good. This is a different patient. Okay, notice that there are darker areas and denser areas. Now, which is normal and which is abnormal? We can't just say, well, this looks really dense, so it's ground glass opacity, because then you're going to misdiagnose it. And frequently, this is called ground glass opacity. So look at the vessels. So these vessels here versus the adjacent vessels, look at the vessels here. These are smaller. But again, that is really hard to tell. And frequently, I don't know. I can't tell the difference. But what I can do is look at the margins between the denser areas and the less dense areas, the more lucent areas. Look at the sharp demarcations here, very sharply defined. So this is an indicator that this is mosaic attenuation. This is not ground glass opacity. In other words, the dense areas are normal, the dark areas are abnormal. And you can't tell that just by looking at the dense area. You have to be looking at the margins. This is mosaic attenuation. This patient also has bronchiectasis, severe bronchiectasis, bronchial filling, as bronchial plugging, as well as bronchial wall thickening. This is a patient with cystic fibrosis, but mosaic attenuation is the finding here. Okay, good. So I gave it away, but that's what the finding is. This is mosaic attenuation with the sharp demarcations. This is not ground glass opacity. Okay, so what is a mosaic? Mosaic is a bunch of different tiles put together with different colors. That was the original term of a mosaic. This is one from ancient Rome, from Pompeii, Italy. You see all sorts of different mosaics. They're often in the floor, or they can be in other places. And that's why we call it mosaic. Okay, now let's go on to differentiate mosaic attenuation from ground glass opacity. That's what we're doing now. So if you see the mosaic attenuation, mosaic perfusion, again, that is the sharp demarcations. That can occur in the setting, that occurs because of poor, let me just pull back a little bit. When we see mosaic attenuation, if there is air trapping, that is an airways disease, like constrictive or obliterative bronchiolitis, bronchiolitis obliterans, hypersensitive pneumonitis, and asthma, if we see air trapping. Okay, if you don't see air trapping, mosaic attenuation or perfusion is caused by the chronic vascular disease like chronic PE or vasculitis. So that's a way to differentiate in the setting of mosaic attenuation. Let's differentiate airways disease, small airways disease from small vessel disease. That's why we do the expiratory views on high resolution CT. Okay, let me talk briefly about this. In the normal lung, this is normal lung, by the way, 80% of the density is due to blood perfusion. What if we remove the perfusion? What if we decrease the perfusion? It will become darker like this. So 80% of the normal lung density on a lung window is due to perfusion. Remove the blood, it will become darker like this. So what does that mean? That means the cause of the mosaic attenuation is due to decreased perfusion. There are two reasons for this. One is small airways disease like chronic PE or vasculitis with the direct decrease in perfusion in patchy areas in the lung. And another cause is small airways disease. Small airways disease causes decreased perfusion because poorly ventilated areas, physiologically, the vessels will constrict in poorly ventilated areas. So this is called physiologic shunting of blood away from poorly ventilated areas. So the blood is shunted away. On an inspiratory view, this is not air trapping. This is a decreased blood flow. Even in an airways disease like cystic fibrosis, this is not air trapping on an inspiratory view. That's decreased blood, shunting of blood away. Another question that people have, this looks really dense. Why is this not the abnormal area? Why is this normal? Well, it's because of the way we do the window and level. It's just that in relatively speaking, this looks denser than this. But if we think about it, this is the abnormal area. That's the mosaic attenuation. Okay, so another patient with cystic fibrosis with these sharp demarcations, also mosaic attenuation. This is not ill-defined demarcation. This is not ground loss opacity. How about this particular individual? This is an inspiratory view. This is normal. How about on the expiratory view? What are we seeing? We are seeing air trapping. So this is air trapping expiratory view. Now, I said it was normal, but in retrospect, is it really normal now that we see the air trapping there? Do we see abnormal areas there? Look at this. Look at this. So it's really subtle, but these are areas of mosaic attenuation. Look at the sharp demarcations right there. Sharp border. Very subtle there, mosaic attenuation. You don't have to see mosaic attenuation with air trapping because mosaic attenuation is generally more subtle than air trapping is. But if you see air trapping, go back and look. But in any case, if we see air trapping, that indicates that it is a small airway disease, not a small vessel disease that's causing mosaic attenuation. Okay, so we're just winding down here. How about this patient? This patient is more unusual. There are three different densities. There's this density, which is darker, this density, which is intermediate, and that density, which is denser. So this is denser, more lucent, and intermediate. There are three different densities here. And notice between the lucent areas and the rest of the lung, there are sharp demarcations. So this is mosaic attenuation. There are sharp demarcations. Look there as well, sharp demarcations, even here. Mosaic attenuation is definitely present. But what else do we have? We also see this, the denser area. Look at between the denser area and this part of the lung, the demarcations are not sharp. They're ill-defined borders. So this is ground glass opacity. So the patient has three different densities. Mosaic attenuation, more normal lung and ground glass opacity. Mosaic attenuation, more normal lung and ground glass opacity. So there are three different densities there. So that is called the head cheese sign, and that's seen in hypersensitive pneumonitis. So let's talk about the head cheese sign. So a different patient with hypersensitive pneumonitis, there are multiple causes of head cheese sign, including pneumonia, especially atypical pneumonia like mycoplasma. But hypersensitive pneumonitis is the classic one. And again, we see the mosaic attenuation, more normal lung, and then the ground glass opacity with poorly defined margins. So three different densities. Okay, so this is classic head cheese sign in hypersensitive pneumonitis. This is an expiratory view, which will, the expiratory view will enhance the mosaic attenuation and show air trapping as well. This is head cheese, by the way. It's a type of meat with different types of meat in it that's all crushed together. It doesn't look very, it doesn't look very nice, but it's a good example of why this why this is called head sheath sign. And actually, the reason the head sheath sign came into being was one of my mentors at UCSF, Rick Webb. He has a daughter who's now when she was in high school, she was helping him with some research, with a research project. And she looked at this and she said, this looks like head cheese. So then they wrote a paper and published it as the head cheese sign because she saw that in the supermarket, in the store, in the market, and called this head cheese. Okay, so now she's now a radiologist. She's an abdominal radiologist at UCSF. Okay, so in conclusion, so there are characteristics of appearances of lobar atelectasis, so that will help us with the diagnosis. So for example, right upper lobe collapse, think about the S sign of Golden, left upper lobe collapse, Lufsical sign, and the veil of opacity. For left lower lobe collapse, the Tribeca sign, the triangle behind the cardium or triangle behind the heart. So those are some things to look at. In patients with lobar collapse, outpatients, think about lung cancer, think about carcinoid, about tumors. So that's really important to remember. In inpatients, it's usually due to mucus plugging or aspiration. Then rounded atelectasis, there are 4 features of rounded atelectasis. There's volume loss, ipsilateral pleural abnormality, broad area of contact with the pleura, and the comet tail sign. And if we see all 4 features, it is likely rounded atelectasis, and then we can say we will follow up with CT because it could still be lung cancer. But if we don't see all 4 features, let's say we only see 2 or 3 features, then we don't say rounded atelectasis. We need to say this could be lung cancer, and we need to do further workup, maybe get a PET CT if appropriate. So then let's talk about patterns of consolidation. If we see peripheral consolidation, think about the differential diagnosis there. Think about cryptogenic organizing pneumonia. Think about eosinophilic pneumonia. And also, there could be an atoll sign in cryptogenic organizing pneumonia with a central lucency. So ground glass opacity is non-specific. The history is key. If the patient has HIV, then think about infections like pneumocystis or viral pneumonia. If the patient has fever, think about infection. If the patient has heart failure, think about edema. But we're not always sure. I will frequently give the differential diagnosis. And then hemorrhage, but only in the correct clinical setting. If it's more chronic, then think about hypersensitive pneumonitis. Okay, so mosaic attenuation versus ground glass opacity. Remember, look for smaller vessels in the dark areas, but that is often very difficult to see. And when I was a fellow with Rick Webb, I said I have a really hard time determining whether the vessels are small. And he said, so do I. I also have a hard time. So I look at the margins. If the margins are clean and well demarcated, then it's a mosaic attenuation. If the margins are ill-defined, then it's ground glass opacity. So that's the best way to differentiate. So mosaic attenuation can occur in small airways or small vessel disease. How do you differentiate if we see mosaic attenuation? Is it small airways or small vessel disease? Well, look at your expiratory views. Small airways disease should have air trapping. Small vessel disease does not have air trapping. But on the inspiratory views, they can look exactly the same. One caveat for small airways disease and air trapping: if the expiratory view is not good quality, then you won't see air trapping. You have to have a good quality expiratory view. And then the head sheath sign, which is a mixture of mosaic attenuation and ground glass opacity, that is often hypersensitive pneumonitis when we see it. Okay, thank you very much for your attention. I'd be happy to take questions. And the other thing I will do is show I will show the quiz cases, but I think I've gone over them. So let me stop sharing. And then there's some questions in the chat that I will answer. Okay. So does the presence of enhancing vessels in consolidation effectively exclude tumor? It does not, because a tumor does. So there are different things. If it's a mass, if it's a true mass, then generally the vessels are either compressed or displaced. But it's still not a that's still not an effective sign. Okay, so it's still not the ideal sign. But just one second. So I'm just okay. So it's still not an effective sign, but if there's a chronic consolidation that's a tumor, or chronic ground glass opacity that's a tumor, in other words, adenocarcinoma spectrum tumor, the vessels are going to look exactly the same because it will just be a consolidation. It's not going to be a mass. So, and then does non-enhancing consolidation mean infarct and nothing else? No, because, well, the pulmonary infarct is definitely in the differential diagnosis, but it could be an abscess. It could be a necrotizing pneumonia. Okay, it doesn't necessarily mean pulmonary infarct. Those are some possibilities, and sometimes a necrotizing tumor can also have the same type of appearance. Okay, and then how to identify consolidation associated with malignancy? Okay, we can identify it just simply based on the time course. If it's chronic and not going away, then the differential diagnosis includes malignancy. It includes lung cancer. So that then needs to have, the patient needs to have a workup. We can do a PET scan. If the PET scan is negative, though, if it's not FDG avid, it could still be a tumor because, as I said, this is one of the causes of false negative PET CT. So the patient might need to have a bronchoscopic biopsy or maybe a percutaneous biopsy or an open biopsy. So if it's a chronic consolidation, especially if it's growing, then we are worried about a tumor. If it grows over the course of many months, then we're concerned about a tumor and we need to do tissue diagnosis. Okay. So let me go over.
One question from my side, Dr.
Please.
Any role for perfusion CT or dual energies CT in terms of differentiating infection from malignancy?
Yes. Some people, there is work that's showing potentially some benefit, especially infections tend to have less perfusion. The thing is that the question I have is, why is that a benefit over PET? That's always what we have to think about. Is any new technology beneficial over what we already have? And there are some benefits potentially over PET in that PET may not be as widely available. There may not be as much access to a PET scanner as to a CT scanner. And if the patient's there anyway, let's say we see a finding on CT, we could potentially just scan them again. But even then, dual energy CT is not that widely available compared to standard CT scanners. So I think there is some promise, there's some potential, but it's not yet well enough established for wide use at this point.
Thank you.
Okay. And then Dr. Kavitha wrote a comment, but it was just to me. I don't know if you meant that, but it says false negative PET due to mucinous content in the tumor. And thank you. So I will bring up the quiz cases, which I think these are essentially from my talk. So I'll go over them quickly because I've already discussed them. And then I'm here for, I can still take questions if people have other questions. So we'll share the screen. Okay, so I'm just going to go over the quiz
नहीं
first.
अभी 8:30 बोला.
I'm sorry, is this, I didn't hear, is this done or we're going till 8:30?
No, please go ahead.
Okay,
It's okay, go ahead.
okay. Because I'm here as long as you have the time. It's still early in the morning here. It's 8 o'clock in the morning, so I have nothing else to do. Okay. So these are the quiz cases. So this is the Luft-Sickle sign here, right there, with the veil of opacity, that's left upper lobe collapse. These are really hard to identify on an AP radiograph if that's all you have. If you don't have the lateral view, if you only have PA or AP, it's hard to identify, so you have to look carefully. Okay, so that's case 2. Actually, I might have accidentally given you the answer there, but this is case 2. This is the 4 features of rounded atelectasis that we discussed. Broad area of contact with the pleura, ipsilateral pleural abnormality, volume loss, and swirling of vessels known as the comet tail sign. This one is a patient with peripheral areas of consolidation and ground glass opacity in the atoll sign. Actually, 2 atoll signs here and here in organizing pneumonia, cryptogenic organizing pneumonia. Diffuse ground glass opacity in HIV, the differential diagnosis here is pneumocystis pneumonia versus viral pneumonia. So very important to include both of them in the differential diagnosis. Pneumocystis is not that common nowadays, at least in the United States. It's not that common in HIV patients because many patients are on prophylaxis or they're on heart therapy, something like that. Okay, so patient with chronic disease and crazy paving, this one is alveolar proteinosis. But this is often seen in the more acute setting. We would think about pneumonia, edema, and hemorrhage. This is a teenager with cystic fibrosis. We can see the bronchiectasis, the bronchial wall thickening, plugging of bronchi here, for example, and partial plugging there. And we can see the sharp demarcations, mosaic attenuation. So cystic fibrosis. And then a more chronic disease, this is the head cheese sign in hypersensitivity pneumonitis. One of the things that occurs in hypersensitivity pneumonitis is that in the chronic setting, fibrosis can start to occur. So that's called the chronic head cheese sign when there's fibrosis plus mosaic attenuation. And that's typically peripheral fibrosis, and it can be lower lobe or upper lobe predominant. If it's lower lobe predominant in hypersensitive pneumonitis, often the claustrophrenic sulci are spared. So way down below, it's relatively spared, even if it's lower lobe predominant with fibrosis. And then if there's honeycombing, that's called the end stage head cheese sign for honeycombing in the setting of hypersensitive pneumonitis. Usually, if we can catch hypersensitive pneumonitis before it's too chronic, before it starts to get fibrotic, then if we remove the inciting factor and treat the patient, then often these findings can go away and the patient can get better. But if the fibrosis or honeycombing has occurred, then it can't be reversed, or at least that portion can't be reversed. So if they can be caught early, it's better. And one of the problems with hypersensitive pneumonitis is if it is caused by birds, then the birds can be removed from the household. Or if it's caused by something in the environment, let's say if the patient is in a farm, then it can be caused by hay that has mold, or it could be caused by bird droppings. So those are all difficulties, and sometimes the patients work there, so they can't be removed from that environment. Okay, so that's it for the quiz cases, and if there are any other questions, I'd be happy to state additional.
There's one question in the chat for you.
Yes, thank you. Okay, how often do we resort to biopsy to confirm a diagnosis? Well, okay, it depends on what the disease is. Do you have a specific disease you're talking about? Because if
Maybe
it's
something like organizing pneumonia versus malignancy. Or...
Yes, okay, so organizing pneumonia, we generally don't biopsy it. We generally don't biopsy it, but if there's a clinical question of what it is, then we will. Because if organizing pneumonia has a classic peripheral consolidation, then we can just, and there's no peripheral eosinophilic pneumonia, then it's likely cryptogenic organizing pneumonia, and they will treat it. The thing is, if they don't do the biopsy and they treat it and it goes away, then it's good. But if it doesn't go away, then we need to do further things, and then we can do the biopsy at that time, and that's usually going to establish the answer. But Dr. Kavitha, I don't know what you mean by PET-CT. Do you mean for organizing pneumonia?
Yes, if it is negative, maybe you can follow it up, or if it is positive, then you can attempt the biopsy, right?
Okay. Yes, that's an approach. In our institution, we don't do that frequently, but that is a potential. Good. And then if there's other things like hypersensitivity pneumonitis, we will generally biopsy it because we need to establish that diagnosis definitively. That will be biopsied. If a patient has honeycombing, we generally don't biopsy anybody with honeycombing because it's already end-stage lung disease. And what are we going to do about it? Nothing, other than maybe a lung transplant. But that's only in a minority of patients who will get something like that. But if they have, let's say, hypersensitive pneumonitis with findings either ground glass opacity or head sheath sign, then we will do a biopsy to look for the identifying features and granulomas that we can see. Okay.
Another question is, we may not get the relevant history in all patients with chronic HP as regards to the allergens. Then how do you proceed in that situation?
Yeah, if it has an appropriate appearance, then we say this is likely chronic hypersensitive pneumonitis, or we'll say likely hypersensitive pneumonitis. And then one option is to do the biopsy to establish it and then to find out what's causing the problem. And sometimes it's never found out what the inciting factor is, and it gets worse. Sometimes it's known. So there are patients who have birds as pets, and they are advised to give up their birds. So they say, okay, I've given up my birds, but the disease is getting worse. So there's a home health visit in which a nurse will go to the home and look for what could be causing the problem. And then the birds are flying all over the place because the patient felt the birds are their children and they don't want to give up the birds. So they're like pets, like, you know, if someone has a dog, they don't want to give up their dog, right? So in the same way, even if it's found, hypersensitive pneumonitis often occurs in unusual situations that it's very hard to get rid of the inciting factor. So Seattle is a place where we have a lot of rain, especially in the wintertime. It rains almost throughout the winter, like 5 days a week in the wintertime, and in the summertime it rains rarely, maybe once a month. So so we have a lot of wetness here in the winter and a lot of wet grass, not hay, but wet, dry grass. So that causes hypersensitive pneumonitis. We see a lot of patients here. Okay, so, and we have a lot of trees with mold on the trees, on the logs. So unfortunately, so that's the downside of getting a lot of rain. We get a lot of rain, we have lots of water, we don't have any drought here ever.